Who is presenting the next one?
Myself.
Okay.
Anesthetic management for pheochromocytoma. Pheochromocytomas are catecholamine secreting neuroendocrine tumors from chromaffin cells of sympathoadrenal system. It is a mostly 10% familial with autosomal dominant associated with Men's syndrome and neuroectodermal dysplasia, 10% malignant and 10% extraadrenal, and 10 to 15% will be bilateral. Site mostly it is adrenal medulla. Extraadrenal sites most common organ of Zuckergandel. It is highly active tumor secreting noradrenaline and adrenaline. 85% of noradrenaline and 15% of adrenaline. Then clinical features most commonly it presents with hypertension, headache, and sweating. The commonest sign is hypertension. It will be sustained or paroxysmal. Other features like pallor, palpitation, perspiration, hyperglycemia, and orthostatic hypotension. Neurological symptoms include anxiety, psychosis, nervousness, tremors, may also present with CVA. The uncontrolled hypertension usually lead to hypertensive encephalopathy. Then in case of metabolic, there will be hyperglycemia, excessive glycogenolysis, and reduced insulin release. The triggering factors include physiological factors like change in position, increase intra-abdominal pressure, defecation, sneezing. Iatrogenic factors include induction of anesthesia, opioids, cold medications, radiographic contrast media, and catecholamine reuptake inhibitors. Usually, diagnosis, screening is usually 24-hour urine catecholamines and catecholamines. Then plasma-free metanephrines are confirmatory for diagnosis of pheochromocytoma. Metanephrines more than 220 picogram per ml or normetanephrine more than 400 picogram per ml. Other tests include clonidine suppression test is also useful, but in pheochromocytoma, the catecholamines are released from tumor cells, so no action in the pheochromocytoma. Normally, it lowers the plasma catecholamines in normal patients. Other tests include glucagon stimulation test, CT, MRI, and PET scan for location. Then pre-op assessment and investigations. Usually, we should evaluate the cardiac status of patient if catecholamine-induced cardiomyopathy. A routine investigation, CBC, hematocrit, then when a sugars level, mostly associated with hyperglycemia, ECG, and echo. In case of pre-op management, you should optimal pre-op preparations of in hypertension. Usually, we give alpha and beta blockers and correction of hypovolemia. Pre-op adrenergic blockade achieves using lower BP should be less than 130/80, and high should be intravascular volume should be optimized, and a decreased chance of hypertensive crisis, allows resensitization of adrenergic receptors, and decreased myocardial dysfunctions in perioperative period. Previously they used Roizen's criteria. Now BP should be less than 130/80 and adequate intravascular volume. Treatment, phenoxybenzamine is a treatment of choice. It is a reversible non-selective alpha-1 blocker. It has a long half-life, so BD dosage is used. Starting dose will be 10 mg BD, maximum 60 to 250 mg per day. Disadvantage, it is undesirable alpha-2 blockade, causes tachycardia, and persistent alpha blockade causes resistant hypotension after tumor removal. It should be stopped 48 hours before surgery. Actually, it should be started at least 7 to 14 days prior to surgery. If a non-selective beta blocker should not be started before alpha blockade, there will be blockade of vasodilated beta-2 receptor. So unopposed alpha agonistic activity will be there. So vasoconstriction and hypertensive crisis. So cardioselective beta blocker can be preferred in that cases. Selective alpha-1 blockers are also used, short-acting, like prazosin, doxazosine, and terazosin. This selective alpha-1 blockers are preferred in pregnancy. There will be no alpha-2 receptor blockade, so no tachycardia. Doxazosine has a long duration of action, so OD dose is preferred, 1 mg to 16 mg if required. Prazosin, 0.5 mg per dose, maximum 20 to 24 mg. It has a short half-life of 2 to 3 hours. Tazosine, 1 mg per day, maximum 20 mg. It has a T-half of 12 hours. Then beta blockers, it to control tachycardia secondary to alpha receptor blockade. selective beta-1 blocker atenolol, bisoprolol can also be used, but non-selective beta blocker propranolol 80 to 120 mg per day is used. Other drugs like calcium channel blockers, ACE inhibitors are also used. Intraoperative management, the choice of surgery can be open or laparoscopic approach. In case of laparoscopic, gas insufflation also produces hypertension due to increased intraabdominal pressure. So our intraoperative goals include avoidance of drugs and maneuvers that produce catecholamine surge, maintain cardiovascular stability with short-acting drugs, and maintain normovolemia and hemodynamics after tumor resection. Routine monitors, ECG, pulse oxy, ETCO2 temperature, invasive arterial BP after before induction, a large bore IV access, and urinary catheters. Anesthetic technique include GA with low thoracic epidural. Factors releasing catecholamine should be avoided. ET tube intubation after satisfactory depth of anesthesia to avoid catecholamine release. We should avoid atracurium and morphine because of histamine release. Atropine, panchronium, succinylcholine as a vagolytic activity causing tachycardia should be avoided. Metoclopramide, ephedrine, and chlorpromazine can also be avoided. The safer drugs include propofol, etomidate, fentanyl, alfentanil, remifentanil, benzodiazepines, becronium, procronium, iso, and sevoflurane. Blood glucose should be monitored. There will be hyperglycemia after tumor removal. There will be increased insulin release as there is a decreased catecholamine. Normothermia should be maintained with forced air warming devices. Then pharmacological options for intraop hemodynamic control. Tumor manipulation can increase in catecholamine levels, can be prevented by a phentolamine, it is a competitive alpha blocker. A bolus of 1 to 5 mg can be given. Most commonly NTG, venodilators given. Sodium nitroprusside, it is a short-acting and potent vasodilator. Other drugs like calcium channel blockers, magnesium sulfates, and we can increase the depth of anesthesia by using volatiles. Catecholamine withdrawal following venous ligation. Refractory hypotension following ligation of venous drainage, there will be sudden drop in catecholamine release. Due to residual alpha blockade or downregulation of adrenergic receptors. The primary treatment will be volume loading before tumor ligations, RLNS. Secondary like vasopressors and inotropes can be used. In case of refractory hypotension, vasopressins can be used. If in case of bilateral adrenalectomy, glucocorticoids can be given if hypoadrenalism is there. Extubated after ensuring hemodynamic stability. Post-op management, we should anticipate refractory hypotension, which is the most common cause of death in case of pheochromocytoma. So fluids and vasopressors should be given. We should watch for hypoglycemia. Steroid supplementations and glucose monitoring for 24 hours. For post-op pain management, epidural and oral NSAIDs.
Very good. Have you done any case of pheochromocytoma or seen any case being done?
No, sir.
It's quite a rare case, unless there is a endocrinology center where these cases will be mostly referred to. So you have covered most of the points. So we just go for the presentation to see